Hi, I'm Michael Patterson from Eye Centers of Tennessee. Welcome to my YouTube channel. Thank you for coming today. You're going to learn through these videos surgical techniques and innovative technologies that you and your staff will be able to utilize to further patient care. Remember at the end of the video to subscribe down here at the bottom so that you can find further content in the future. Hello, this is Michael Patterson from Eye Centers of Tennessee. I want to show you our approach here on small pupils. We don't use any pupil expanding devices during my surgeries, and there's a reason for that. You can see here we always use the Patterson double diamond technique to enter the eye, where we use a side port stabilizer in a main wound. We'll place some lidocaine with epinephrine in the eye on these cases just to try to get a little bit more dilation, though very difficult. You have options of Malyugin rings, you have iris retractors, and you've got pupil stretch, which is a great option, but in my case I typically just like to leave the pupil completely alone. I use the Callisto markerless system just to kind of give me an idea of where the rexus should be, and I'll use the cystotome to start my rexus in small cases, and then typically just use Utratas to just feel the rexus as it goes around the iris. And you can really see this, that it's really nice and smooth with the edge of the iris without any problems of concern of a run out. You typically can feel, any experienced cataract surgeon can feel whether the rexus is running or not, and in this case no problem, as you can see. I take a regular, just normal hydrodissection cannula, nothing special. There's all sorts of varieties, but I think you can use just about anything. I make certain this lens will rotate, but the highlight of this case is going to be not just that the pupil rotates, not that we can do these type of cataract surgery safely. It's going to be the Stellaris phaco system from Bausch & Lomb, and there's a reason for that. When you're doing any other surgery with a phaco machine that you have to reach and grab objects, the Stellaris is not like that. You can grab this and do a phaco chop completely under the iris, spin the lens, no different here, and then the Stellaris does not have to be moved. You don't have to grab pieces to get occlusion, and you can see here we can use the Stellaris machine right in the center, and then use your chopper to just gently pull pieces to the phaco tip. You don't have to do anything. Not one time during this entire case does the pupil become touched by the phaco device, and you can see that because the Stellaris can stay directly in the middle and the pieces will come to it as long as you use your chopper to hold posteriorly. Now some people say, well, why would you do it this way? Well, the reason is the pupil doesn't have any distortion. You don't have any extra inflammation in the eye postoperatively, and the patient is much more satisfied with not having an irregular pupil from a Malyugin ring or iris retractors, of which many of these people end up with small hyphemas and things of that nature. You can see here that the pupil stays kind of where it is. We use the Stellaris phaco machine, and we just gently use the chopper to kind of get our pieces in position. We're never moving the phaco needle outside of the pupil. Just slowly get each individual piece up, and you'll see that they nicely come through. What is a dense 2+ nuclear sclerosis cataract. This is not a soft cataract, though a soft cataract would come straight up quite easily. And then you'll see there just the last remaining pieces of the nuclear sclerosis. And then I take my chopper and just try to visualize around just to make sure I don't see anything. Sometimes I'll take a Y-hook in this case to really isolate, and this is just an epinuclear shell coming out that's really smooth. Again, you've noticed the phaco handpiece has never even had to go towards the end of the bag. While the pupil stays right at the same position the entire case, it will not get any larger. I use a curved tip IA handpiece on these cases. This is an unedited case that will take 6 minutes and 48 seconds. There's zero editing in this whole video. I wanted to show the entire case. This is how we do these, and you'll see here with the IA handpiece, you'll see just we're making sure we've got all this stripped out. We want to stay low, but the nice thing about the curved IA is you don't really need a lot of visualization if you stay right underneath the capsule edge, and you can see the cortex coming out nicely and how clear the posterior capsule is becoming. You can just watch as everything starts to clear up, and then we'll take the IA and we'll just make sure that everything's good. We will inject some viscoelastic into the eye and show you here that the pupil doesn't get much larger, and we've got a very strong cohesive viscoelastic, and then we use the Li61AO in these cases. And one thing I like about it is you don't need pupil dilation. It's already completely unfolded, instantly planar position right into the capsular bag, and then we will go in to really confirm that. And you'll notice here I'm going to actually, no matter what, every case I go underneath the optic and I remove all viscoelastic outside in the capsular bag. I don't like leaving any viscoelastic posteriorly. I've seen too many capsular distension syndromes and you need YAGs for it, and so you just want to take out all of that. And then here you'll just take a hydration cannula and try to irrigate the eye and inflate it, and you'll notice here we're at 5 minutes and 18 seconds and we're pretty much done with this case. We're going to place a little antibiotic steroid combination into the eye. I think I see an extra piece. You say, oh, well, you could lose a piece. Well, yeah, so we're going to go in and see if we see it, and we bring the eye tip. There's nothing wrong with doing that. We see that we move the lens just to make sure, and nope, we don't see anything else, and so we'll leave it and we will irrigate the wounds once again. You'll see here that no piece was under the iris, and we'll put in an antibiotic steroid combination that's clear. I like to use a moxifloxacin mixture compounded with solucortef, which gives you a clear steroid and antibiotic in the eye, and then I'll do a subtenon Kenalog, just non-preserved, just right under at the end of the case. The patient doesn't feel it, and you'll remove the lens. That's the end of this case. This is Michael Patterson from Eye Centers of Tennessee. Thank you for watching.